This is Brian Draper speaking, and I'm chairing the session today on interventions addressing the behavioural and psychological symptoms of dementia. The Australian Dementia Network acknowledges the traditional custodians of country throughout Australia and their continuing connection to land, sea and community. We pay our respects to all Aboriginal and Torres Strait Islander peoples, their cultures, and to the elders past, present and emerging. Just to tell you a little bit about ADNET, it has three main initiatives. It's obviously short for Australian Dementia Network, and has two support packages. And they collaborate closely to achieve three main aims: to improve the quality of care, harmonise and improve diagnosis, and to speed the development of effective therapies. So firstly, I'd like to introduce Associate Professor Nadika Dissanayake. She's an NHMRC Boosting Dementia Research Leadership Fellow and directs the Dementia and Neuromental Health Research Unit at the University of Queensland Centre for Clinical Research. And she holds adjunct appointments at UQ Psychology and Department of Neurology at Royal Brisbane Hospital and Women's Hospital. She's co-chair of the ADNET Early to Mid-Career Researcher Accelerator Group and chair of the UQ CCR Consumer and Community Involvement Committee. Professor Sunil Bar is a professor of psychology at Swinburne University of Technology. He is director of the Wellbeing Clinic for Older Adults at Swinburne University Mental Health Counselling Clinic for older people living in residential aged care homes. He leads an active research lab focusing on the emotional well-being of older adults. His research focuses on the application of reminiscence and cognitive behavioural therapies for older people living with depression, anxiety, or dementia.
And today I'm going to talk to you about technology-assisted interventions to reduce behaviours of concern and psychological symptoms in dementia. First of all, I'd like to say thank you to ADNET for inviting me to present today. I'm from Brisbane, and this is our centre, UQ Centre for Clinical Research, and it's located at the Royal Brisbane and Women's Hospital. Like Brian said, I direct the Dementia and Neuromental Health Research Unit there, and we have a large number of dementia research projects ranging from dementia prevention and dementia care. And we target all settings ranging from hospitals, community and aged care settings. And a large number of people are involved in our studies. And I'd like to acknowledge everybody involved, in particularly my postdocs and students who have done a marvelous job with all the work that I'm presenting today. So the focus today is our technology theme, in particularly looking at how we can use technology to improve behaviors of concern and psychological symptoms in people living with dementia. So we all know behaviors, change behaviors, responsive behaviors, behavioral and psychological symptoms, or neuropsychiatric symptoms. These are all the words, terminology used to describe these changes in behavior that impact quality of life of many individuals living with dementia, as well as their families and care supporters. So what we want is to think about avenues that we can improve quality of life and reduce some of these behaviors and psychological symptoms that impact people. So I'm going to focus today on a number of psychological symptoms and a series of pilot studies that we have conducted within our center. So the objective within our technology theme is to develop a suite of technology-assisted applications to increase engagement, assist with psychotherapy, and to ensure that there is a wider outreach to people, in particular people living in remote and rural communities. So I'll focus first on a series of studies that we conducted looking at how we can use virtual reality innovation to assess interventions. First of all, we did a systematic review examining how virtual reality is used in individuals with dementia, or also known as neurocognitive disorders. So in this international systematic review, we demonstrated that virtual reality, in fact, has been used in people living with dementia, in particularly focusing on cognitive training. But behaviors or psychological symptoms were examined secondary to cognitive training. So there was some data on how virtual reality can improve functionings, in particular cognitive functioning as well as psychological functioning. But we were one of the first to examine using fully immersive virtual reality headsets, as you can see here. That's in particular the wireless headsets, and focusing in particularly on psychological symptoms. So we had to conduct a number of feasibility studies. So our first feasibility studies using virtual reality or VR was focused on is it acceptable, is it feasible, and what are the psychological improvements we can see in people living with dementia. So we applied a commercially available VR application for 10 minutes in one session for people living with dementia. In particular, we looked at a range of severity in terms of their cognitive impairment. And secondly, we did a second study looking at how VR in groups work with over 6 sessions during a period of 3 weeks. And these 2 studies that were conducted in residential aged care settings informed us to help with develop VR-assisted psychotherapeutic interventions, in particular looking at focused on cognitive behavioral therapy or CBT. So I'm just going to present these 3 studies in detail now. So the first study where we focused on 10 minutes exposure of virtual reality. In this study was focused purely on looking at how these headsets, virtual reality headsets work, whether it's feasible, is it acceptable in people living with dementia. We had 13 residents with varying cognitive impairment, and there was a wide range of their age, which ranged between 66 and 93 years of age. And we applied one VR session and examined how emotions changed, as well as whether there was a change in apathy pre and post VR session. In particular, we looked at qualitative aspects, including qualitative interviews of the use of VR. So this study was well received. We did not see usual side effects that we see with virtual reality administration, in particular using fully immersive experiences. And the session content included various virtual reality experiences of interest to people that they could choose between various experiences. For example, walking in a beach or walking in a forest, some of the things that people living in residential aged care no longer are able to do. So we did see improvement in many people in terms of their facial expression, contact. In fact, we actually had one person who was living with dementia who was non-verbal and haven't really come out of their room for a very long time, but wanted to try this VR, which was an amazing experience. It was well received, as I said, and many people did not want to take their headsets off, so 10 minutes wasn't really enough for them. So it was feasible and acceptable, and secondly, looking at how did that improve their emotions, in particularly in this study, it's a very small study, we saw some indication of reducing apathy. So this led us to think about, if we design psychotherapy, there are multiple sessions involved in psychotherapeutic approaches. So we wanted to see how VR is received in people living with dementia if we administer over several sessions. So here we administered VR sessions, 6 sessions over 3 weeks, but we also altered, rather than giving the sessions individually, we wanted to look at how groups will work. Again, this was a small feasibility trial of involving 25 people of a wide range, and noting that we had about 28% of people with severe cognitive impairment. Again, this study, which was published, and it was well received. People did enjoy being in groups. And secondarily, we saw some reduction in depression. And I must say that for this study, we purposely recruited a selective sample of people who had indication of depression and who did not indicate any depression. So this is again an uncontrolled pilot study to understand more about how VR works when we administered wireless VR using fully immersive experiences. So those 2 pilot studies gave us really good information for us to go ahead and develop a VR-assisted cognitive behavioral psychotherapy. So why should we use VR to assist psychotherapy? There can be challenges using traditional psychotherapeutic approaches, in particularly when people have mobility issues. If, for example, if you think about treating phobic disorders of anxiety, and it might be quite difficult to provide exposure therapy for that people with mobility issues, whereas VR offers a safe alternative exposure and can provide that graded exposure that is typically used in exposure therapy type psychotherapeutic approaches. People who have cognitive difficulties may have difficulties mentally producing imagery stimuli, which can be overcome by providing this immersive VR environment. Some people may have difficulties in paying attention, but when you apply virtual reality, it can reduce some of these distractions by wearing the headset. And again, VR can also help to remember content. Otherwise, that is usually verbally delivered in sessions. And VR could be a really great experience in terms of home-based practice as well. So, and it may provide opportunities for remote delivery of therapy at the same time. So we had a series of studies that we conducted, in particular looking at how to reduce anxiety in people living with Parkinson's disease, because people living with Parkinson's disease also have comorbid cognitive impairment, even from very early stages of the disease. So in this particular study, we already had evidence base to suggest that cognitive behavioral therapy reduces anxiety in Parkinson's, and we provided design considerations to incorporate VR into CBT. In our VR-assisted CBT package, we developed a number of versions of it to cater for subtypes of anxiety disorders, and it included psychotherapeutic psychoeducation with using videos and we used VR to develop imagery for relaxation and also for exposure hierarchy. And we used VR to practice some of the stimuli of anxiety evoking provoking situations. So participants were provided the VR headset to take home, and they were trained how to use VR in psychotherapy sessions. So psychotherapy was delivered by postgraduate trainees of the UKIW Advanced Psychology Training Program. And we also had carers participate in this study, and carers could also be VR, and we trained them how to use headsets. So this study was conducted. It's a pilot study. We had 7 people completed this study, and it was well received. Also, the pilot study helped us to do modifications to our psychotherapy program. But this is an example of simulations. We made our own videos using a co-design process, including people with Parkinson's and dementia, as well as their carers and family members, which was an enormous experience for us to do. This is an example. So, so COVID hit, which we had to hold this project. And COVID, one of the fortunate things that happened with COVID is for us to start thinking about how we can use this VR-assisted technology to remotely deliver psychotherapy using telehealth. So we developed a new protocol of 6-week psychotherapy using some of the videos that we created for our VR-assisted psychotherapy program. And we developed a new program in particularly focus on reducing anxiety in people with dementia. So support persons are welcome to participate in this study, and we've completed quite a few people now. And this is a DCRC funded project of a randomized controlled trial, and we are currently recruiting for this study. And anyone can participate in this study from anywhere in Australia. So the eligibility is having mild cognitive impairment or dementia with anxiety. And you can find more information following our website, and you can also sign up following the website. So, and we deliver 6 weeks of psychotherapy in a randomized controlled trial, and we gather both qualitative and quantitative information for us to understand more about feasibility of administering psychotherapy via video conferencing. So we were fortunate to receive a large MRFF fund grant to take this technology portfolio into the next level. So in here, we co-designed and developed a new technology platform called My Anxiety Care that allows people with dementia or cognitive impairment to connect with the therapist and also use these resources that we developed as part of psychotherapy program or the CBT therapy program using the platform. And another really interesting thing that we incorporated is to use digital assets like Amazon Alexa to produce to help with home-based practice, so that people don't actually need to go in front of a computer to access these videos. They can use a voice command using Alexa to play their videos using My Anxiety Care, the Alexa voice app. So this has now been developed And we are just about to test usability and acceptability of this platform and the voice app in the hybrid randomized control trial. So the RCT, which is looking at both feasibility of this new program, and also we're looking at a process evaluation as well as an economic evaluation of using the platform as well as the voice app for home-based practice, together with delivering psychotherapy remotely using video conferencing in this study. So if anyone's interested, feel free to get in touch with us, and we are very happy to provide more information about this study, which will commence very soon. So in summary, I hope that I have given you an idea that a flavor of how we can use various technologies. For example, virtual reality technology, telehealth using video conferencing, as well as new technologies like digital assist to help with assist with psychotherapy to augment results of these psychotherapeutic programs. In particular, we were focusing on anxiety because it's one of the biggest problems in people with dementia, and it's an undertreated problem. So our program of research is funded by a large number of funding bodies, and I'd like to acknowledge all funding bodies, funders of our project, and thank you so much for your attention, and feel free to get in touch.
Hey, hello everyone. Nice to spend a few minutes with you. As Brian said, my name is Sunil Bhatt. I'm from Swinburne University in Melbourne, and I'd like to spend about 20 minutes talking about a study that we completed now about 3 years ago, focusing on cognitive behavioral therapy for depression and anxiety in dementia in aged care residents in Australia, a cluster randomized trial. The idea was to bring together technology and person-centered care to enrich the quality of life of older adults living with dementia who also lived in nursing homes. The study was funded by the Department of Health, and we conducted the study in collaboration with Dementia Australia, and also acknowledging some key collaborators, Mark Silva, Rebecca Collins, Deborah Koda, Jahar Bovmik, and Raj Bivwas. My aim is to really unpack the study for you and to share with you what we've learned in the year and a half that we spent in the study, and then of course to tell you about what we've done subsequently, what we've learned, and how we've tried to disseminate our findings more broadly. Just by way of background, we know that there are approximately 340,000 or so aged care residents living in Australia at the moment. And we also know that most are diagnosed with some form of dementia. And of those people with this diagnosis, about 50% have significant levels of depression or anxiety at any one point of time. Yet there is very little evidence for the effectiveness of psychological treatments for depression and anxiety in these aged care residents. And furthermore, the access to support is extremely poor. Residential care staff, clinicians are poorly trained, and there are very few allied health staff who are able to help individuals with dementia who live in residential aged care sites. And as a result, as we've discovered, there is, as some people put it, an over-reliance on medication, often bringing in side effects and so on. Now, once you throw COVID into the mix, we've also learned that the situation has worsened in residential aged care. Throughout the years of COVID, we have discovered, according to the staff who work in these facilities, that levels of loneliness, anxiety, depression, challenging behaviors, and even death and suicide ideation have spiked due to various factors, including the restriction of access to families and friends in many of the facilities, the changed routine in many of the residential care facilities, and so on. there is a very strong need for research to try and work out what is it that's going to help older people who are living in residential aged care, particularly when they have dementia. So with that in mind, we were fortunate enough to get some funding from the Australian Government Department of Health under their Dementia and Aged Care Services Fund. And the study was conducted by Swinburne University of Technology in Melbourne in collaboration with Dementia Australia and 21 residential aged care facilities within the Melbourne and Greater Melbourne area. And the aim of the study was to examine if cognitive behavioral therapy, or CBT, was associated with significantly greater improvement in depression, anxiety, and quality of life for aged care residents with mild to moderate dementia compared to usual care. And so instead of randomizing individuals to either receiving the intervention or not, we randomized facilities, we randomized aged care homes, and that's why we call this a cluster randomized trial. So the trial involved 21 residential aged care facilities in Greater Melbourne, and residents were referred by staff to the trial. Residents were eligible if they were 65 years old or older. They had a diagnosis of dementia registered in their facility file. They were assessed as having mild to moderate cognitive impairment, according to the PAS cognitive impairment subscale, sometime within the last 6 months, and also had significant levels of depression or anxiety as registered in their case files. So over the year or so of data collection, we collected together a sample of 124 participants. As you can see, the average age was about 87 years old. We had people ranging from the age of 65 all the way to 100, all diagnosed with dementia. Just over a third was female, most born in Australia, most speaking English, and most having some secondary school. And the level of impairment was in that mild to moderate level as determined by our screening tool, the MOCA. To try and work out whether or not the treatment would have any benefit on the residents, we administered 3 measures to track their levels of depression, anxiety, and quality of life. For depression, we used the Cornell scale for depression in dementia. For anxiety, we used the RAID, the Rating Anxiety in Dementia scale. And for the quality of life construct, we used quality of life measure, specifically for Alzheimer's disease in nursing homes. The one interesting feature of all of these measures, for those of you who are yourselves researchers or thinking about researching people with dementia, is that we needed to find measures where we could include proxy ratings, because some of the people who we were working with could not self-report, they could not attend to a questionnaire. So we needed to blend together the opinions or the observations of residential aged care staff, of research assistants, of families, and so on. So all 3 measures allows for that blending in some way. Now, the treatment comprised of the following. We randomized facilities either to treatment or to no treatment. All the facilities were allowed to receive usual care. So all of the usual group programs, medication regimes, social recreational outings were allowed to continue. We collected data before the COVID years. That's important to know, right? And so it was virtually unrestricted. Facilities could do whatever they usually did. However, the facilities that received treatment received 3 components. The residents received individual sessions with a therapist. The staff received education and support, and the families received education and support as well. And so we referred to this as a trifocal treatment because we had those 3 components. And we're very aware that in order to be effective with individuals living with dementia, we had to do more than simply provide one-on-one therapy with these individuals. We needed to include their care system. And that's why we're very eager to support the families and the residential care staff. So I'll describe the first component and then I'll move on to the second and third. The first component involved 20 face-to-face sessions of CBT with the individual diagnosed with dementia, and that went for about 6 months. Just like in Nandika's case, we used therapists who were our postgraduate students. These were students who were studying psychology, social work, or counseling, all under supervision, of course. And the treatment program involved the usual candidates for managing anxiety and depression under a CBT framework: anxiety management skills, behavioral activation, cognitive restructuring, and reminiscence. And like I said before, this treatment was augmented by a systemic approach where we included family and staff where possible. To give you a more fine-grained look at our individual treatment component, we separated the program into 7 modules. The program was highly manualized. However, therapists could adjust and modify the approach to suit the individual resident. The first 2 sessions, Module 1, included an introduction to therapy, a discussion of goals, as well as a discussion of logistics, such as how many times a week the sessions would occur, where they would occur, and so on. The next module, including sessions 3 to 5, was focused on anxiety management, providing the individual with psychoeducation about anxiety, conducting an assessment about the levels of anxiety, and teaching them some very simple relaxation skills so they could manage their own levels of arousal and anxiety. Module 3, which went from sessions 6 to 9, was focused on behavioral activation. This is a very common, in fact, this is one of the most common interventions in residential care settings, where residents are encouraged and helped to engage with pleasurable and meaningful activities. And we did that with the individuals in our sample. Module 4 was focused more on worry management, helping the individuals to distract themselves from worry, as well as to use coping self-help. Module 5 focused on frustration tolerance, where the residents were taught simple techniques for mindfulness as well as self-talk. Module 6 was focused on reminiscence, a reviewing of the individual's personal memories, enjoyable memories, important experiences, and we spent quite a few sessions reminiscing about the past. And the final module was focused on relapse prevention and a review of what worked, what was enjoyable, what was beneficial about the treatment for the residents. The other 2 components, focusing on family and staff, involved education and support. Now, to educate staff about dementia, we partnered with Dementia Australia, who have their own virtual reality program, but not for the individuals living with a diagnosis, but for the professional and family carers. And this is the program that helped the carers to experience what it might be like to have the perceptual abnormalities and confusion that comes with dementia, right? So the carers would put on the goggles, as you can see in the picture, and the challenge would be to walk from the bedroom to the bathroom of a typical house and to try to work out which direction to walk in and how to make sense of the play between light and shadow, and to experience the frightening experiences that an individual with dementia might have when they can't really make sense of their surroundings. And the primary aim of this virtual reality program, called EDDI, was to develop a sense of understanding and empathy amongst the professional and family carers so that they could be more in tune with the person living with dementia. In addition to the education component, we also invited the families of the individuals in our study to attend monthly support groups, and we ran these groups on site at the facilities. And we also met with residential care staff so that we could have monthly exchanges, not only providing the staff members with our experiences of working with the residents, but also to involve staff members where possible in the co-development of the treatment. So this slide presents very simple data. It looks at the baseline and post-treatment scores for 3 variables: depression, anxiety, and quality of life. And as you can see, the study resulted in improvements in all three constructs. For those people who were receiving a treatment, so those individuals living in our treatment sites, compared to the group that experienced an escalation in depression, those individuals who were receiving treatment did not worsen with their depression levels. The same pattern was observed with anxiety, where individuals in the control arm seemed to increase in terms of their anxiety levels, whereas those individuals living in intervention facilities appeared to decrease in terms of their anxiety. And in terms of quality of life, we found that the individuals who were receiving treatment experienced an improvement in quality of life, whereas those in the control arm, in other words, in facilities that weren't receiving the treatment, appeared to deteriorate in terms of their quality of life over that 6-month period. So in summary, there are some indications, right, that the intervention was statistically significant or statistically effective in improving or maintaining mental health for the aged care residents with dementia. So I want to provide a couple of learnings, and I'll start off with just a description of how the treatment looks on the ground, because sometimes treatment packages like this can sound very complicated, but when you drill down to what actually happens, you'll discover that it really requires a clear conceptualization of what might be maintaining the depression or anxiety of the aged care resident and coming up with simple and feasible strategies to try and lead to improvement. So this is a case study of a client who we call Eleanor, who was 81 years old and diagnosed with Alzheimer's disease 5 years before she entered the study. Her symptoms were rapid forgetting and reduced verbal fluency primarily. Her big complaint was that she was extremely lonely, and this was the basis of her depressive symptomology. In fact, she would often say to the clinician who was visiting her that other people, meaning her family and friends, are too busy to visit. In fact, the reality was, and many of you who are listening to this would probably experience this as well, is that people would visit her, but she forgot these visits. And she was also very frustrated by the lack of physical activities within the facility. She was physically quite mobile. It was just that she was in there because she wasn't able to live independently. So with the help of her therapist and her son, we discovered that Eleanor had a real interest in paintings. And so we helped Eleanor to paint little postcards and could mail off to her friends interstate. And her son helped with this project. We also installed a whiteboard in her room so that when visitors did visit Eleanor, they could write down a message or write down that they visited. And Eleanor was encouraged through the lifestyle staff to join facility activities. None of these interventions were terribly complicated, and none of them, I would suggest to you, are different to what other facilities would have done. But the therapists, through the help of facility staff and the son, were able to curate together, to put together a package that was effective for Eleanor. And towards the end of the treatment, Eleanor reported feeling happier and more settled, and this was echoed by family and staff as well. Staff often asked us, what can we do to help our residents reduce the levels of depression and anxiety? Very well for you as therapists to come in once a week or once every 2 weeks, but we're here all the time. What could we do to try and improve the mental health of aged care residents? And our learnings from the trial were as follows. Number one, be part of a team. Don't think that you can do it all. Staff need to collaborate with families, with the resident, of course, and with counselors in the sector to try and put together a package that might work for an individual resident. Of all the different techniques that we used, we found that reminiscence had a great resonance with the resident. Residents seemed to really enjoy reminiscing about the past. And by accessing those longer-term memories, it appeared that the residents seemed to feel in control rather than feel disoriented. We encouraged the residential care staff to facilitate activities, not just to keep the resident busy, but also ones that were meaningful for the resident. And that required the residential staff to know something about the residents' backgrounds so that they could organize activities that resembled those that the resident enjoyed doing. We also encouraged residential care staff to use anxiety management strategies and to remind the resident to use coping strategies or coping statements as well as thinking skills, just to remember that things might not seem as dire as they imagined them to be. And when we finished with the trial, we did leave behind a wellness plan, and we certainly encouraged the residential staff to use those wellness plans. Now, since we completed that trial just before 2020, we've discovered, and you might know this, that there are a number of different services that are currently in existence or that has emerged over that time. And this is a slide that points to a changing landscape in terms of mental health and residential aged care. At Swinburne University, over the COVID years, we developed the National Telehealth Counselling and Support Service. Anyone can refer aged care residents to that service, as well as family members and staff. Many of you would know about the Carers Gateway, where families can receive support, and the Victorian version of that, Carers Victoria. Over the last few years, primary healthcare networks have been funded by the federal government to deliver psychological services into many aged care facilities, and some of your facilities might be involved. We know that because of the Royal Commission's report, Medicare now funds psychology services within residential aged care, just like it does in the community. Some of you might know about the community visitor schemes that links community volunteers to aged care residents. The Australian Centre for Grief and Bereavement have also received funding to bring psychological treatments into residential care facilities. And of course, many of you would know about Dementia Support Australia and Dementia Australia, both resources, particularly for those living with dementia. And so we are open if you'd like to refer clients to us. We are funded by philanthropy and research grants. All of our services are free to aged care residents living anywhere in Australia, as well as their carers. So thank you very much to Adnan for inviting me to present just on our research, and I'm going to hand back to you, Brian. Thank you.
Thank you, Sunil and Nardika, for your presentations. They were both very interesting. We have some questions here in Q&A. A few of them, I think, could be answered by each of you, because I think they probably, even though they may have been put up for one particular presentation, they'd be relevant to both. So the first one, which I think is relevant to both, is from Samantha McMaster, who asked you, Nardika, but I think it would be relevant to you, Sunil, as well, is about, you mentioned dementia stages in your study, Nardika, and what about the participants having, what particular types of dementia did they have? And did they, was there any measure of the type of dementia that they had? And did that make a difference, I guess?
It's a great question, thanks. No, we did invite anybody with any type of dementia. We did not measure, or we did not sort of identify in terms of what specific types of dementia, but was measured using the same measure that PAS that was used in Sunil's study. Anyone scored higher than 4 in the PAS. Sorry, yeah, and PAS, a cutoff of 4 was used to identify cognitive impairment.
Sunil?
Yeah, very similar answer. In fact, we expected that most of the people in our study would have Alzheimer's. In fact, about 40% had Alzheimer's, and the remaining had a variety of different dementias. And because we did not diagnose dementia ourselves, we relied on the notification in the files within residential aged care. And close to 40% of this notification said that the dementia was undefined. There wasn't a specific notation. So we are a little bit in the dark about what that meant. But it was a mixed group of people with different kinds of dementias. And of course, you can have more than one. So we have said that we have a mixed group of dementia diagnoses in our sample.
So my follow-up to that question to both of you, just for a brief answer, do you think it would make much difference, having a different type of dementia? Are different types of dementia more likely to respond to either of your treatments?
Because we are looking at, particularly with our studies, first we were looking at engagement in terms of using VR, and the studies that we looked at, anxiety, again, it's anxiety. There may be certain differences, in particular if you think about people with Parkinson's disease, and with cognitive impairment, the rates or frequencies of different subtypes of anxiety can differ between different dementias, but that didn't really bother because we were looking at anxiety as the primary outcome measure. But that's a great question and something we can think about when moving forward as well. Thanks.
Yeah, I'm not wanting to sound like a broken record, but I think that's an empirical question for us. Our sample size was not large enough for us to do these kind of subgroup analyses, just focusing on one particular subgroup. But that's a great question. In short, we don't know the answer to that question. It may have an impact that our package may suit one cohort. We did try and homogenize the sample by selecting people who met our eligibility criteria. In other words, they had to have mild to moderate levels of cognitive impairment. They had to cross the threshold of depression and anxiety. And so that was how we tried to homogenize the sample, but not by the brand of dementia that they carried.
Okay. And now I'm going to go down to keep you on the same sort of theme. A question from Douglas Taylor. I think it's Douglas, or it says Douglas. I don't know if that's just a misspelling there. And he raises the issue about why don't we talk about reactive depression anymore, and particularly in the context of COVID and all the stresses that people have been under, and he's just making that comment, and that perhaps we're using the term endogenous or a little bit more rather than reacting to a life event. Would either of you like to make a brief comment about that?
It's a great question. Another great question, I think. So we used a Cornell scale for depression and dementia as a measure. So depression could be both endogenous and reactive. It's a bit of both, and in some cases, for some cases it could be the reactive case, whereas the others, the endogenous is the greatest sort of contributor to depression. So our studies were mainly focused on anxiety, and depression was addressed secondary. So you do need to address, I guess, both, but our package was more of a generalized anxiety treatment rather than a depression treatment. And if depression was the primary concern, we did not include them in our anxiety studies because we need to treat depression rather than anxiety as a focus. Sunil, you probably can add more.
I remember studying about endogenous and reactive depression in the early days. Those words have seemed to kind of gone off favor for some reason, even though there's huge literature basis for each one. I think that in our approach, we were somewhat agnostic to the origins of depression. Endogenous refers to kind of a biochemical or biological origin, whereas reactive tends to imply a kind of a social trigger. We didn't go to trying to determine the origins of why people were feeling depressed. And so in that way, we were somewhat blind to the origins. But I suppose that's an interesting question, isn't it? Does it matter how depression started as to what we then do? And that's also one of those open questions. So thanks for that.
Okay. Linda Henderson raised an issue relevant to both your studies, and that is, what about people who have language or communication difficulties? How can they be attended to with your work?
So virtual reality is great in that way. Like I said, in the virtual reality study, we had someone who was nonverbal, but they still participated in the VR because that bypasses the need to think about imagery or build up. So that's great. So that's why we're looking at, in particularly, how technology can assist for these different subgroups of people. which are usually quite difficult to treat in traditional methods.
Yeah, we were somewhat restricted in our study. We made it a condition that people had to be able to speak and to understand to receive our study. However, there are other ways, of course, of engaging people who are not verbally proficient or able to speak. Using music, exercise, using the arts and humor have all been seen, as well as aromatherapy, have all been seen to be very, very effective, haven't they, in trying to engage people and enliven them. And there have been some remarkable results with those studies. So I think we're at this cusp of trying to really understand what works and what doesn't work, and for whom. And now that we have more research going on in residential aged care, and we certainly encourage that, I think we're at the stage of now asking those more fine-grained questions.
So in fact, Michelle Ferris raised that sort of issue in her question. And she was interested in your thoughts, Sunil, to start with, and Nadika afterwards, about reminiscence being used to enhance alongside music therapy, and using combinations, I guess, of therapies in that kind of way. What are your views about that? I think you sort of implied it already, but maybe talk a bit more.
I think it blends together the best of both worlds. In fact, one of my PhD students has just finished a PhD on that very topic. We know that reminiscence is one of those treatments that has a great great sense of face validity. It resonates with people of all ages, particularly those in their later years. And we know that reminiscence reduces depression. And we know that music reduces agitation. And so what we're doing is we're putting those two things together, aren't we? So that we have a powerhouse where reminiscence is augmented by music and vice versa. So I think that's a winning combination, if you don't mind me saying so.
Yeah, I think I completely agree. It's just looking at various modalities and various therapies combined together can certainly augment the outcomes of the interventions that we're looking at, rather than looking at one individual. So I completely agree with what Sunil was saying. Thanks.
A question that Paul Regal raised specifically to you, Sunil, but in a way would be relevant to Nadika too, and it's about the small sample size that in your study. Why was there a sample size of an average of 6 residents per nursing home?
Yeah. We fought very hard to get that sample. So in our view, that sample is actually one of the largest samples in studies that focus purely on psychological treatments in residential care facilities. And I think there are a couple of ways of understanding that. Number one is very few psychology researchers are trained on how to recruit within residential care facilities. And the second way of understanding that is very few residential facilities have a culture of research. I think that we're changing the culture slowly with grants such as this, but what we need to have better partnerships. Universities and residential care facilities need to work together so that we can communicate what these studies are about, and we can talk more effectively with families and staff about the need for research within facilities. We are tapping into a group of people who generally do not participate in psychological research. This is one of the hardest groups in our view to recruit. So we have learned a lot about what to do and what not to do. So the sample of 124 was one that we had to fight very hard to achieve. But you're quite right. Statistically speaking, it is not large enough because it does not allow us to do those fine-grained analysis.
That's right. I must say it's not easy to recruit people. And there's a lot of changes in terms of behaviors and the attitudes towards this type of interventions that needs to be done within aged care as well. Our studies were pilot studies, so we were not targeting very large sample sizes because they were pilot and more looking at the acceptability and usability of the technology. The current randomized control trial, we are actually targeting a much larger sample size of about 70 people living with dementia or mild cognitive impairment and their care partners as well. So that will be one of our largest studies within this space. So,
okay. It was just about out of time, but there's a question. One question is from Alice Matson, is about how you go about consenting participants with cognitive impairment. I won't let you go there. It'll take too long. It'll take the whole presentation to do that. But Matthew Green has just asked, what is the effect of social interaction between carers and people with dementia encouraged by technology? And I think that's an important element, using the carers. So I'm sure you both agree, but any quick points that you want to make about that? Nadika?
Totally agree. That's why we do have the support person in many ways, social interactions, as well as helping people to with the technology. So we do encourage the support person or the care person to be with them when we deliver the therapies.
Yeah, I would echo that.
And I'd like to thank Sunil and Nadika for your great presentations, and the people for asking some good questions that really, you know, kicked it off towards the end to provide us a little bit of extra understanding. So thank you all. I've enjoyed this, and hope to see you next time. The next one will be in a few months' time.